for anatomic, whether it's computed tomography, CT venography, or MR venography, compared with the conventional venography that Don Ponick was talking about. Ultrasound is certainly better at identifying interluminal lesions, and I showed you an example of that, but it is very operator dependent. It takes a lot of training. It's time intense. It's hard to blind. If you're an ultrasound tech, you probably know the person you're examining whether they have MS or not. It depends on multiple criteria, which are kind of changing and in flux, and it's difficult to reproduce from site to site. And even though we might want it to be able to reproduce, the fact is that's not the real world. Catheter venography is invasive. Experience suggests that although it's the gold standard, that gold standard may be somewhat tarnished when we talk about CCSVI, because as Jack alluded to, there's all this confounding things of whether your muscles are contracted or what your state of respiration is, or how your neck is twisted, this and that you can potentially, even with conventional venography, make or take away lesions. So there's an emerging recognition that it's critical we understand the physiological relevance of any anatomic imaging finding. So that means flow, or perfusion, or oxygenation, or whatever. And that's what people are working on. And in retrospect, I don't think we should be blamed, because we came in this a little naively thinking veins were, at least in this application, going to be kind of like arteries. And in arteries, really, the anatomic imaging is sufficient. You know, it really is. We know from a long history of dealing with coronaries and legs, etc., when we see a lesion, we can pretty well correspond that to what the physical symptoms are going to be and how significant it is. But when veins, it's very different, and it's not easy. And in the end, I think the evaluation of CCSVI will not be a zero-sum game where there's going to be one modality that has a dominant role that kicks everything else out of the equation. Rather, it's going to be this combination between anatomy and physiology, not only in terms of diagnosis, but in terms of monitoring and surveillance post-therapy. So I'm not going to spend a lot of time on this, except I've banged on this drum for a long time, and that's the idea that CCSVI, the common thread, is venous obstruction. It's not really that important, except when you come to therapy in terms of what you might do, where the lesion is, or what caused the lesion. It's the fact that that lesion has created some sort of venous obstruction, and the result of that, consequently, is that you've got flow abnormalities, etc. So you can see this. Again, this is a pi at C1. This is the lateral mass of C1. This is the vein. That some degree of narrowing here is normal, especially supine. But as we know from neurosurgery, a certain percentage of the population has extreme kinking in this area. So this is the C1 lateral mass. This is posterior. This is anterior. Here's the jugular vein. And this is because neurosurgeons were having problems post-craniectomy in certain patients. They were doing tumor removal when they positioned the patient like that. And these patients would wake up, and lo and behold, they'd have a stroke. But it wasn't a stroke in anywhere they were operating, and it wasn't even an arterial stroke. It was a venous stroke in the posterior fossa, secondary to theory, positional kinking of this to really obscuring or obliterating all venous drainage. It's like May Turner for the interventionalists. You take people in the ER who come in who have nothing wrong with them whatsoever when it comes to their veins, have a very low, what we call a thrombotic index, and they may come in for kidney stone or something, and you look at their iliac veins, up to 50% of people will have a 30% narrowing of that iliac vein. And again, it's just like the veins in the neck, very volume dependent, how many liters of fluid have you had, etc. And up to 30% of these patients will have a 60% narrowing. Likewise, it's a spectrum, a range here when we talk about C1. And at one end of that range or spectrum, you have kinks, which may be positionally improved or may be positionally worsened. But the point is, no one can walk around in a certain position all the time. They live sort of neutral. Overwhelming majority are obviously have something to do with the valve, some aspect of the valve. We've talked about this and some examples of valves that were actually upside down at surgery. I think many of you may have thought about this, but when embryologically, congenitally, when we're all put together in utero, there are a lot more veins than there are arteries. And obviously all the veins have valves and none of the arteries do. So potentially the opportunity for screw-ups in terms of congenital abnormalities is far greater in veins than it is in arteries. And we just never kind of really think about it because, in point of fact, in my world of radiology, we use the term normal variant all the time. And the reason something's a normal variant, it doesn't mean anatomically it's exactly perfect, but it means that we don't have any disease or any abnormality to ascribe to it. So we have to call it a normal variant because if it's not normal, what is it? It's happening well if we don't have a disease or a name to stick on it, you know, that's a problem. So here's a patient. I just showed this. I'm sure either Justin or Dr. Saxon will show this. This is a valve problem, but also this is the carotid. And you know, this again, by turning the neck, can be made worse or better. But this is an indicate that basically a wavy, gravy carotid bifurcation, which creates this medial impression. Other locations, azygos. I just thought I'd throw this in because there's some weird things you see in the azygos. And this is an area of controversy. I didn't know and was somewhat not surprised, but was good to put in my memory bank that you guys have 71% of your azygos. And this is a big, you know, you can go talk to like Simka in Poland and he's 5%, you know. Zamboni, a lot of azygos. Other people, not so much azygos. It's clearly they're the same page, but we're just, again, we don't have that interpretation down right here. But when you do see it, it can look something like this candy wrapper twist here in the azygos, this sort of bird beak, if you will, and then filling up retrograde branches, collateralizing around it. Here's another one of the same, and they often, you know, they look like this. And yes, there's a valve, tends to be a valve in this area at the SVC junction, but there don't tend to be valves in other areas, like this patient. Now you look for the interventions, you look at that, nondescript, but it's a little funny, a little smudgy. You look a little more, and you start seeing all of these valves here. And then you see this going around to bypass those valves. And if I could show you fluoroscopically, this is like sort of like a ladder. Blood would flow here, stop at one valve, go up to here, stop again, go up. It's pretty dramatic. And here you can see an outline of a valve. So at least 3 or 4 valves, and they're just not supposed to be there. And here you can see I'm above all the valves now, and there's draining back reflux through that valve. Same here. So, what's the history? I'm going to pop through this quickly. Endovascular management. We in interventionals have a lot of experience dealing with veins, the chronically occluded vena cava, superior vena cava, iliofemoral, but in terms of using stents or angioplasty in the cerebral vascular disease, there's a body of information. These are just some of the articles we've written about it over the years. And on the venous side, this is, I think, the first patient that I treated who was a law student at Emory University in Atlanta, and she came because of an absolute tortured by almost disabling ringing in her ears, tinnitus. And she'd go to the law library at Emory, and she couldn't concentrate because there was this machinery rumbling in her ear, so she couldn't read, she couldn't, you know, it was hard to memorize, etc. And when she was studied, she obviously had this transverse sinuses that on both sides appear narrow, okay? And it turned out that the side that was obviously the least narrow was not the one with the tinnitus. It was the other side that all the blood was being shunted through, so she had increased flow. That's usually the case. We see this from time to time. So I treated the one side here with a stent. This happened to be in the old days with a wall stent, for those who are wondering. And because wall stents didn't come on a delivery system that would reach from the groin up, we went through direct jugular puncture. And she was a little queasy about that, so we did it under anesthesia. And when she woke up, the tinnitus was gone. And again, we see these things from time to time. And now, of course, how this has evolved, this is the treatment for pseudotumor benign intracranial hypertension. This is what now people get treated with. And we're not talking the same level of hypertension or pressures in the brain with CCSVI, but just gives you an idea of how this is sort of evolved. Okay, why do we use stents? I don't want to defend stents at all, but I think based on our experience using stents for lower extremity veins in the pelvis, we do have a lot of experience with that. We sort of know what to expect. Obviously, we use balloon angioplasty Always we use it first in all cases. But if angioplasty is ineffective or after repeated times there's recall, stents can be effective. However, they're permanently implantable at this point. Bioresorbable stents are ready to go into trial. They're already in trial in the coronaries, and maybe soon we'll see, at least outside the U.S., the opportunity for similar devices in the legs. But PTA and stents are sort of on the spectrum. We always, as Don said, like to use angioplasty, but certain lesions, and again, there's a gamut of lesions responsible for CCSVI, you know, is not always going to be effective. With stents, however, you may get re-narrowing. That's really common in dialysis patients, not quite so common in DVT, and it has to be dealt with. So we always use plain old balloon angioplasty first, especially effective in valves, annular lesions, membranous lesions, stents as a last resort when there's residual stenosis, residual pressure gradient, residual collateral flow, residual symptoms, etc. Are there any FDA-approved stents used? Well, no. There's not an